Healthcare decarbonization and what can we as anesthesiologists do. And I also want to emphasize what a big role anesthesia plays in the contribution of greenhouse gases and how healthcare can actually lead the way. And we as anesthesiologists are a crucial, important part of all of this. So with that, I want to thank the Malaysian Society for inviting me. And I'm excited to speak to you guys for the next 40 minutes. I have no disclosures to share and no financial disclosures. And the only disclosure I have is that I'm on vacation right now and I'm giving this talk from UK. I'm in London and the time here is 2 a.m. in the morning, but still very excited to be here. Climate change is irrefutable. In the last decade, we've seen some of the warmest years recorded on history. We've seen worsening floods, we've seen fires. Even in places like Asia, I know Malaysia is going through a lot of flood and rising sea levels. So across it globally, we've seen the impacts of climate change. In fact, in California, where I am, and I've been in California for about 15 years now, we have what they call now as a fire season, because the fires have been the highest, most rampant fires in the last recorded history. Climate change is irrefutable, but climate change has a big impact on health, on the health of the very patients that we swore to take care of. It affects every system, right? It's going to worsen respiratory illnesses. Heat is going to affect cardiovascular illnesses. With the change in temperatures, vector-borne illnesses are going to change. We've seen worsening malaria, dengue, and encephalitis. Climate change will affect every single system. But the thing is that most of these effects are actually not recognized by us as the impact of climate change. And in fact, last year was the first time that one patient in Canada received a diagnosis of climate change. And it really made big news in the Western Hemisphere because people talked about how the practitioner felt like the patient did not have any other predisposing conditions that they could establish as a diagnosis other than climate change. Recognizing all of this, in 2015, the Lancet Commission, which most of you know come out of the UK as one of the most reputable bodies and as one of the most reputable bodies, international bodies on climate change, said tackling climate change could be the greatest global health opportunity of the 21st century. I am very fortunate that I'm in California and at the University of California, which does have a visionary goal, which wants to be a leader, not just in clinical care, but in also community care and social care. In 2015, the University of California pledged to decrease and go carbon neutral by 2025. So we have a huge effort going on here, and I'll share some of that in the future. Right. Now, while all of this was happening, finally last year, the headlines in New York Times was President Biden and 40 nations planned to decrease emissions from healthcare. Now, why are nations suddenly focusing on emissions from healthcare? And we'll talk about that more. But following from that, I wanted to put in perspective is there are many Asian countries, right? Laos, Nepal, Indonesia, Pakistan, Sri Lanka, a lot of these countries have pledged to decrease their emissions from healthcare. While there were a lot of other industries, and we know that there are electric cars in the world and the food industry and solar energy, a lot of other industries are really taking account into their emissions. But because we felt like emissions from healthcare were a collateral damage of providing this healthcare, it wasn't really held accountable. And now the National Academy of Medicine, in an international collaborative, has come up with a lot of task forces to agree to decrease the carbon footprint of US healthcare by 50% in absolute terms compared to 2010. So this is a huge move that has happened with the 40 world leaders signing it. Right. So let's look at why all this focus on healthcare, right? And the reason is that about 4.5%, and these studies vary depending on which study you read, but it's safe to say that between 4 to 5% of all the global emissions come from healthcare. And this is something that we need to really pause and think about. And especially for people like us in the US, because for us, healthcare accounts to 8.5% of all our national emissions. And that's a big number. That's nothing that we can take lightly, right? A similar study in Australia said that 4% of emissions from Australia, 3.5% from India, and about 6.6% of China. All these emissions are attributed only to healthcare. So if we were to take healthcare just and put it as an island, healthcare would be the sixth largest emitter in the world. Healthcare has negative impacts of health. The emissions of healthcare contribute to respiratory illnesses. The emissions of healthcare contribute to a lot of the problems. Do no harm was the first thing we decided to swear, right? The Hippocratic oath that we all took. But the practice of healthcare itself is very, very polluting. So where do these emissions come from, right? We talk about emissions from healthcare, and what concerns anesthesiologists like you and me is, where are these emissions coming from in a hospital, in an acute care setting, and what can I do about it? Now, globally, emissions are divided into three things: Scope 1, Scope 2, and Scope 3. And what we do as anesthesiologists impacts every single scope. So for those of you who don't know, Scope 1 is what the anesthesia gases are. Any hospital, any acute care setting, the greenhouse gas emissions from that setting is counted as Scope 1. So all anesthesia gases are Scope 1. In addition, if a surgeon is doing a laparoscopic surgery and uses CO2, then Scope 1 includes CO2. Refrigerants come in CO2, and the energy that's used for those buildings come in CO2, right? In Scope 1. Scope 2 includes things like purchased energy and stuff, and I won't get into much details in that. But please look that the bulk of this is Scope 3. And this model was for US, and I'll share something similar for the UK. And a lot of other countries don't have similar models for us to go out of. But it's very important to know that Scope 3, everything else that runs this machine, all the supplies we use, all your syringes and your drugs and you coming to work, the medical supplies and MRIs and CT scans, and the production that happens in the back of all of this, the food and water and energy, everything comes in Scope 3. So whatever we do, all choices we impact will impact Scope 3. We could come up with the greenest vehicles and a completely solar building, but till we don't consume less as a society, we will not go towards carbon neutrality. Now, having worked in India, and I go back to India often, and I'm in London actually for pleasure, but also for work here, I've realized that US is very, very polluting and very, very wasteful, which should not be a surprise to anybody in the room. And in fact, there are things that are happening in a lot of Asian countries that we need to emulate. There are practices from India that we're bringing back. But what I also often see is that this trend in a lot of the developing nations to emulate the wrong practices that happen in the developed countries. The use of more single-use devices, the new use of Desflurane, which now we're trying to eliminate and India is trying to adopt. So there's a lot of things that are happening which is not happening in the right direction, but more importantly, from a financial perspective, from a resource perspective, it's not sustainable. So the emissions that come from healthcare is about 8.5% in the US. Now that emission accounts, if you look at the blue bar, that's what hospitals are, and it accounts to smog formation, ozone depletion, acidification. Greenhouse gases is just one part of the whole equation. So that's something that we really need to take into account. Dr. Jody Sherman in the US, and she's at Yale, and she's done a lot of work, and we're collaborating on projects to really see how we can learn from the developing countries and how the developing countries can learn from the developing countries and really build together a global health system that is more sustainable to help us take care of the very patients we promised to take care of, right? So what is the role of an anesthesiologist? Why am I talking about sustainability? I know that the speaker introduced me and said that I was the medical director of sustainability, the first one appointed in the University of California system. But as of today, there are 10 or maybe 11 medical directors of sustainability appointed nationally. And of that, 6 of them are anesthesiologists. So why do anesthesiologists play such a crucial role in sustainability? One thing is that if you look at departments, right, surgery and radiology or pathology, anesthesia is usually the larger department in most countries, in most departments. Second is we really span a big part of the hospital. You see patients in the pre-op clinic, you see patients intra-op, you see them post-op, you see them in the pain clinic, you see them in an obstetric practice, a lot of places in the ICU, in trauma settings. So we do see a lot of spectrum of practice. And that's why we as anesthesiologists are in a crucial role. But in addition, the practice of anesthesiology is extremely polluting. And this might seem like a surprise to many people in the room, and it definitely was to me when I started my journey more than a decade ago, right? So this is a study that came out, and which again came out in the Lancet, and was really talked about a lot, because it's the first time that it happened across 3 continents. A, B, and C here. A is Vancouver Hospital in Canada. B is the Minnesota Hospital in US, and C is the John Radcliffe Hospital in the UK. And what they did is they just looked for 1 year, the carbon emissions from 3 different countries, and they tried to map it out in the operating room. And they picked similar sized tertiary hospitals and mapped out the carbon emissions. And you can see that A and B anesthesia gases account for about 50 to 60% of carbon emissions. And while C is the UK, accounted for only about 4 to 5% of carbon emissions. And if we were here live talk, I would ask you why that the case is. And the case is solely for one thing. It's because in Canada and in the US, Desflurane was used a lot more than in the UK. And I hope that Malaysia is also close to UK, where people are not adopting the use of Desflurane a lot. Now, I can say this because Desflurane was invented at University of California, San Francisco, an institute where I practiced, an institute where I finished my residency training. So it took a lot of struggle, but we were finally successful because we have a visionary chairman who was able to say, we will follow science, we will follow evidence, and we will eliminate a gas that we actually invented in our practice. So similarly, this is a paper that came out that compared the carbon footprint of hysterectomy done 4 different ways. They looked at 16 patients each, in which hysterectomy was done abdominally, vaginally, laparoscopically, and robotically. And for everyone in the audience, I want to first focus on the purple bar. And the purple bar is the impact of anesthesia gases on the total carbon emissions of the surgery, right? So next time a surgeon tells you that they're important, tell them you're as important, because look at the amount of emissions you're producing. So as an anesthesiologist, if you do these cases under general anesthesia, vaginally or abdominally, the way you use your anesthesia gases is a big component of the carbon emissions of that surgery. When we come into laparoscopic and robotic stuff, done under general anesthesia, you can see that the light green bar suddenly widened. And this light green bar is really the carbon emissions from single-use devices. And I know that there's a big trend, at least in the US, to try and do everything robotically. The evidence for robotic surgeries is really lacking, but you can see that the carbon footprint is going up, right? I know when I trained in India, we did a lot of our hysterectomies under spinal anesthesia. And in fact, I think in a few years, that's what people might go back to, not from an emissions perspective, but also because you can discharge the patients home faster, and also because of many other financial implications from that. So let's talk about anesthesia gases. And I know in the last 2 slides, I talked about how impactful they are, and especially about Desflurane. So we want to talk about, at least in the US, the most common used gases, and I don't have halothane here, and I don't know if you use halothane in Malaysia, but I want to highlight on nitrous oxide, sevoflurane, desflurane, and isoflurane, and talk about how long they stay in the atmosphere, which is the lifetime, and about global warming potential, and then differ that into what flows you use the gas for. Now, what is GWP? What is the global warming potential? By definition, the global warming potential of carbon dioxide is 1. And the global warming potential is the intensity of the mass of gas in producing warmth. So if you compare Desflurane is 2,500 times more warming than carbon dioxide. Sevoflurane about 100 times more warming than carbon dioxide, and isoflurane about 500. So you see, using Desflurane is significantly worse than using Sevo, nitrous, or isoflurane. That's the first thing. The second thing is, how long does the gas stay in the atmosphere? And for that, I want to draw your attention to nitrous oxide, because nitrous oxide stays in the atmosphere for about 110 years. And this differs. Every 2 years, we get a report from the EPA, but approximately 110 years is how long nitrous oxide stays in the atmosphere, right? Now, let's talk about how we use these gases. So if you use low flow anesthesia, and if you use 0.5 liters per minute, then you're able to use Desflurane that will only produce you can drive 93 miles an hour. I've converted global warming potential to miles per hour. But if you use sevoflurane at 5 liters, you're driving 19 miles per hour in a car. Or if you use it at 1 liter, you're driving 4 miles per hour. So the point of the slide is that if you haven't, you should eliminate Desflurane. If you haven't adopted it, please do not, because we've eliminated it. And whatever anesthetic gas you use, please use it at flows that are low and only take into account leaks in the system and oxygen consumption for the patient. Of course, safety of your machine and avoiding a hypoxic mixture, depending on the machine that you're using, should all be taken into account as well. But the other thing I also want to talk about is nitrous oxide and the efforts that are happening nationally and globally to really eliminate nitrous oxide as well. So I often get asked, and the primary agent we use now is propofol for induction. And I often get asked is, oh, how about the carbon footprint of propofol compared to the gases, right? So Dr. Sherman and her team have done what they call life cycle analysis. And life cycle analysis is basically a cradle to grave approach, where you take into account procurement, manufacturing, transport, utilization, disposable, every single thing that goes into the whole process, and get carbon emission, working with carbon emission specialists. So if you look at propofol in the bottom, you can barely see the emissions of propofol. If you look at Desflurane on the top, the emissions are huge, because we all know that Desflurane also needs a specialized vaporizer. Isoflurane less than sevoflurane, and propofol hardly any. Taking into account that propofol needs a pump, it needs a syringe, it needs a tube. Even with all of that, the emissions of propofol are a lot lower than inhaled gases. There was a similar study that just came out of Australia to corroborate some of these findings. But mind and while that propofol has to be disposed of, it has to be incinerated, because if it gets into the water, it's very toxic to the aquatic life as well. So I wanted to share our journey, and as I said, moved from UK to San Francisco, and for many years I adopted the practice there. I had my kids, but then finally when I got into the sustainability area, I realized that we were using Desflurane. And it took many years, because the drug was invented at UCSF, to finally come to a point where going from about 40% of our cases done with Des, in 2019, only 3% of our cases were done. And then by 2020, we were successfully able to eliminate Desflurane from all our practice. But then remained the question of decreasing our flows. And probably not the case in Malaysia, but in the US, the FDA, which is our governing body, said that because of the potential problem with compound A, we had to use drugs, especially Sevoflurane, at 2 liters per minute, because they were worried about compound A and renal injury. Now, most of us know that these studies have not been corroborated in humans, and definitely countries like New Zealand, Australia, and UK never accepted that compound A could be created. So they always use low flows. And we saw that in the Lancet study that UK only carbon emissions from gases are 5%. So the next task for me was to actually take on decreasing flows. And we employ electronic health record systems in most institutions here. So I was able to create a tool where every time we use more than 1 liter, or now it's 0.7 liters, and you can definitely go lower than that, a little menu popped up reminding our providers to change their practice. And our providers then decided to change, decreasing low flows. So the point here is, please consider the gas you're using. Use the gas at the flows it should be used, because you know that these stay in the atmosphere for a long time and they have a very high global warming potential. So switching gears, because there's a lot to talk about, let's just briefly touch about nitrous oxide. So this was some of the benefits that we achieved, and we've just been accepted to publish in ANA, so you should have that in the next or 2 issues. You saw the big change that we had in our liters. In 2016, most gases were used at 2 liters a minute, and by 2022, we're using a lot less. This also not only just saved the mLs and decreased our emissions, but also we were able to decrease cost per case as well. So let's switch gears and talk about nitrous oxide. And this was produced in BJA, and then there's a couple more articles that have talked about how majority, 90%, 80 to 90% of the nitrous oxide that you actually use in a pipe system gets vented into the atmosphere and never goes to the patient. There's a big discrepancy in the amount of nitrous oxide that you purchase versus that's clinically used. So we collected data at UCSF for 5 years to really match out our consumption and our usage. And we found, our procurement, our buying of nitrous oxide and our usage. And I want to share last 4 years worth of data. Clinically, we purchased, as you can see, much more than we used. And in 2017, we only used 17%. In 2018, about 22%, and in 2020, about 10% of the nitrous oxide, which meant that about 80 to 90% of all the nitrous that we use gets vented into the atmosphere. Nitrous oxide doesn't get much credit because majority of you, as you know, comes from cattle and farming. But healthcare still has to play a part in it. And especially for institutions like UCSF that have committed to carbon neutrality, we also have to start buying carbon offsets, and we'll have to start paying a big penalty on the amount of gas that is wasted. Nitrous stays in the atmosphere for more than 100 years, and it also affects the ozone layer. So it's something that we as anesthesiologists can employ is, if you have piped nitrous system in your major hospitals, it's time to talk decommissioning. And we just agreed and we signed off as a health system to decommission nitrous oxide. If you are using smaller e-cylinders in your machine, it's time to think about how many e-cylinders are needed on machines. And the bigger question is, with newer drugs available like propofol, it's time to think about whether or not you should be using nitrous oxide at all. So Moving gears from anesthesia gases, I wanted to talk a little bit about operating room waste. And I produce this very humbly because I know that some prelim work that comes out, and my personal experience having traveled in a lot of developing countries, from Haiti to Dominican Republic to UK is not a developing country, but I've practiced here, India, I've seen that there's a lot that we can learn, and there's a lot that we can reuse that we don't already reuse, right? But the studies show that about 20 to 30% of the waste from all hospitals come from operating room. And we audited about 150 cases and found that each surgical case generates about 28 to 55% of pounds per weight. So then we decided to just see where our waste comes from. And a lot of our waste comes from wrapping papers, positioning devices, surgical towels, drapes, a lot of surgical gowns, which is all single use here at our institution, some supplies that get unused and thrown out, packaging material, plastic. And so we were finally able to sort of ascertain where it comes from, and in each area decide how we want to set a performance metrics dashboard for us, right? And as I mentioned before, that this is a study where Cassandra Teal basically looked at cataract, which is one of the most common surgeries done globally, and compare how the amount of waste that's generated from cataract surgeries in India, at the Arvinda Eye Institute, which is one of the biggest eye institutes, and in the UK. And essentially, if you look at it, in UK, 132 kilo metric tons of carbon dioxide is attributed to each cataract surgery, while in India, it's only about 6 metric tons. And we know that there is a lot of outcome data that there is no difference in these outcomes. And some of these policies are basically set by institutions that are self-limiting to themselves. So it's really important to see what lessons we can learn from each other to really decide how to improve our practice, right? And one of the big ones that stood out from an energy consumption standpoint was that in India, they have a shorter autoclave cycle. So that is really important as well. And more studies need to be done, but there's a lot more work that needs to be done in sort of collaborative global way. But these are some of the few studies that we could find. And we're working with Dr. Thiel right now to really compare the carbon analysis and life cycle of a laryngoscope that is single use versus reusable. Right. Now, I'm sure that you guys have experienced, and there's been a global shortage of supplies. We've all seen it, and especially with COVID, right? So we're trying to really decide whether our current system of using supplies that we do, whether that is going to be sustainable, and what we can do to decrease our reliance on single-use devices. Now, we have to understand that single-use devices were sold to us in the 1980s as a fear of spreading CJD or mad cow disease. And that's how single-use devices really made it big in the market. And there are multiple studies that infection does not depend on using single-use or reusable devices, but it depends on hand washing. It depends on patient factors. Those things need to be taken into account. And the carbon footprint from producing the single-use devices has expanded so much that itself is affecting our health, and it's not a sustainable practice. So we're really trying to sort of turn back the clock in some of the things that we did before. I'm not going to touch much about because there's not much time, but something that we're trying to really incorporate is cost awareness. Because healthcare is also talking about cost. We are a $3 trillion economy in the US. When I take my kids to the market, I always talk about, this is how much the tomatoes cost and this is how much a potato costs. I think similarly, our residents and our trainees and our practitioners need to know about cost of things as well to help them make educated decisions. And we think it's a cultural taboo to talk about cost. This came out of our institution, University of California, where they asked urology providers on, do you know about cost of things? And most people were off by multiple folds on cost of things. We did a similar survey in our Department of Anesthesia using some of the most common drugs, and a simple thing like lactated ringers or saline. And we found that only about 20%, in one case 50% of people actually knew about the cost of things. So cost awareness, climate change, and the impact that anesthesia has on climate change are things that should be incorporated into our curriculum. Right. So coming back to some of the things that we were using as single use, that we use reusable now. One such example is isolation gowns. So patients that have Clostridium difficile or any other isolation where you need protective gear, and COVID is one big example right now, where people were using single-use gowns. We've tried to convert it now to reusable gowns. And it saved us about $100,000 a year and prevented landfill diversion, about 120,000 pounds prevented and diverted from landfill. So all our ICUs in the University of California Health System, even the COVID ICUs, we do not have single-use isolation gowns. We use reusable gowns that are washed. Technology has moved on, and there are newer gowns available with great fabric that are also comfortable, but most importantly, safe for the provider and the patient. Right, so we're trying, you can see all our surgeons right now, and we've just finished this pilot at 2 hospitals where all our surgeons are wearing reusable gowns, and they took this picture on Earth Day. We did a pre and post survey, and that will be published very soon as well. And 88% of the surgeons were really happy with using reusable gowns. We're doing a life cycle analysis to see how much carbon and water and stuff can be saved by changing from single to reusable. Right. So this came out of the NHS, and again, carbon footprint across different things, similar to the scope 1, scope 2, and scope 3 slide I showed you before. And I pointed out here in red arrows are things that we as anesthesiologists can do, right? Medical equipment, we should only open the number of syringes that we need to open. Only draw up drugs, because pharmaceutical, the second arrow there, is a big component of carbon emission. Only draw up drugs that we need. Have syringes available. Think about the drugs we draw up, right? Surgical devices. Use only devices that are absolutely essential, and if there's an option that's available to use reusable devices, we can use that. There's a lot of effort now because carbon emission of patient travel is huge. So when the technology is available and if the patient has access, start thinking about having tele meetings. For pre-op visits, is there a way to combine things? Is there a way to combine post-op visits with the patient visits, decrease the emissions, decrease travel, decrease commuter travel, even of the providers? Can meetings like this, imagine me going to Malaysia and having a meeting, the carbon footprint of me actually driving to that meeting, right? So there's a lot of things that we need to consider. Anesthesia gases and nitrous oxide is one part of it, but it also should start with, does the patient need the surgery, right? Should we do this or no? So thinking really top down and not just bottom up. Because a lot of time when I go to speak, people also talk to me about recycling. While it is important, I think there are other things that are a lot more important in our practice. This is a great paper if anyone wants to read, by Forbes McGain, who is in Australia, and Jody Sherman, who's here in US, where they've really compiled everything together on evidence-based sustainable practice for anesthesiologists. Now, I know some of this you might look and go like, we already do it. And I think that Malaysia might be advanced, and in some areas, India is definitely advanced. But there are definitely things that everyone can take home. Some things like anesthesia gases, right? What is the flow? What is the gas that I need to use? Should I just use Tiva if possible, right? Can I just use propofol? Even more, can I just do this with regional anesthesia? Can I do this with a neuraxial anesthesia? Can I drop only the drugs that I need and not waste drugs? That's something really important. How can we bring back more reusable stuff, right? Hats, gowns, so there's a whole culture, the whole trend, the whole corporate pushing of using single-use devices based on infection, right? The one big one I wanted to point out here, and this is especially pertinent, and I wish that I was live because I would get feedback, and if there's possible at the end, I would like to hear it in a minute, on anesthesia circuits, right? We have filters on the patient end. In US, we use circuits only one time per case. While as I know in UK, they use it for 7 days, in Australia for 4 days, in Germany for a whole day. So this is something that we in US need to adopt and bring back sort of a sustainable practice based on evidence, right? So lots that we can do as anesthesiologists. But the biggest thing, and I don't want to overrun, but I want to leave you with this message, is recycling is at the tip of all of this, at the bottom. What we have to do as clinicians and scientists and educators is really rethink how we're providing our care. Rethink whether we need a single-use device. Rethink whether the patient needs surgery. Rethink how we're doing things. Every single thing. We have to start questioning it. And we have to stand up and refuse. We have to stand up in boards and meetings and societies to start refusing single-use devices, right? Reduce where necessary. And all these photos or cases or QI projects or publications we have where we've made effort to look at our practice and change our behavior. We use hotlines to give warm fluids for patients that receive massive blood transfusions. And we felt like that wasn't used appropriately. So that's something that we did. Or pulse oximeters. We have single-use pulse oximeters here, and I sure hope that you guys don't, because there's a lot of that doesn't happen in the UK, which is where I'm right now, to really knowledge share. So that's something that we can focus on, right? Another thing that we're doing here, and I don't know how it works in Malaysia, is we're also trying to look at scope 2 emissions, and hopefully we should have some data and a publication out very soon on how much energy is consumed in the operating room and what are the flow cycles for the ventilation and air conditioning, and if that can be set back to match the occupancy of the operating room. So hours that it's not needed, if we can set it back. Also, how many devices are left plugged in and how many computers are there in every OR? We did a basic audit, and just some results is about 22 to 26% of equipment was left connected. So we're trying to see if we can come up with a shutdown checklist. It's a lot we as anesthesiologists can do. But we can't do it alone. We definitely cannot do it alone. And we need an entire system to focus on this. We need our stakeholders. We need our politicians. We need policymakers to be involved. We need device makers. And this just came out in the New England Journal of Medicine. And the sentence it said is, everybody in healthcare that contributes to the carbon footprint should energetically and publicly seek to reduce it. And it includes the pharmaceutical companies, device makers, policy makers especially. All of us together will make a big impact in decreasing the emissions from healthcare. So a few key takeaways is, why should we as anesthesiologists care? And I hope I've made it abundantly clear that anesthesia gases and the practice of anesthesia is very impactful. You saw the 3 studies comparing carbon emissions from operating rooms. And everywhere anesthesia gases were significant. Even in UK, they were counted about 5% of the ORs. The study that talked about hysterectomy done different ways showed that anesthesia gases contribute from 20 to 60% depending on how the hysterectomy was done. So for us, the way we use our anesthesia gases, because they stay in the atmosphere for a long time and have a high global warming potential, are very important. Safely using anesthesia gases at low flows is very important, and considering our use of nitrous oxide. Drugs, attires, single-use devices, a lot of other things, telemedicine are what we as anesthesiologists can have an impact on. right? And I often get asked is where should I focus my efforts and where should I start? And my question is start somewhere. Pick something that bothers you. Pick something that you find is faithful and start there. And then once you start, you'll need to build a multidisciplinary team involving surgeons, nurses, hospitality, supply chain people that buy your products. And then making a case for value, not just an environmental value, but also an economic value, because sustainability at the end decreases waste and decreases waste and helps decreasing the cost per case. And that's what your administrators and that's what the CEOs all want to hear. So I think that those are some of the things and tips that I wanted to share.
Thank you for your attention. See you next time in my other lectures.